Welcome to the Low Carb MD Podcast. No one is beyond help. No one is beyond hope. Nothing said on the Low Carb MD Podcast is medical advice. Please consult your own doctor before making any lifestyle changes.
Hello and welcome back to the Low Carb MD Podcast. Tro, we're reunited again. You know how I say I told you so, but remember, Tro, when those doctors were attacking us for saying that we're seeing our patients' mental health getting better, depression, bipolar disorder, and this big study just comes out and says, oh my gosh, that was 5 years ago. Remember, it was the doctor that's a pediatrician that was attacking me for like 4 days. I don't hold grudges, but maybe I'll send it to him. What do you think?
So Brian, so if you're a listener right now and you want to get clued into what Brian is alluding to, Brian 6 years ago, 7 years ago was talking about mental health and the improvements in addiction that we saw. And he was attacked for mentioning that diet can have an impact on mental health. And the field of mental health has just boomed. Maybe Jack will put in some of the show notes on those new studies that have been out.
Yeah,
And
we'll put some links in there for
Brian
people.
has been vindicated. Brian has been vindicated. Yeah, Brian, I'm happy. I'm happy you've been vindicated with a lot more than that. So,
A
you
lot
know,
more.
yeah.
A lot
So
more. It's just
let
observation, Troy. That's what we do. We do observation. You see stuff, you go, look, why am I seeing this? And then you start looking into why you're seeing it. As a matter of fact, interestingly enough, just yesterday, I saw my fourth case of LADA in a 65-plus-year-old female that's thin and healthy. Never had sugar problems before, four in a row. I mean, not four in a row, but four over the last 2 years I've never seen in my career before. I go, I wonder why. If I look in the literature, guess what? There's case studies of the same thing, of people seeing the same thing. And we have the same causative agent. So anyways, those kind of things, you start observing it, you go, this is weird. That's what we do. And so,
Well, I think
but
everybody's got to recognize what you're alluding to right now, which is we know that there are sort of infectious precursors or immunologic precursors to autoimmune disease. But I think we have a clinical pharmacist who can help us understand
yes,
all of that. He's so eager to talk about all this controversial stuff, like the immunologic triggers of autoimmune disease. He just can't wait to talk about it, I'm sure. We're very lucky today. We have Austin Dudzinski. He's a doctor, PharmD, clinical pharmacist. He works in a pretty big primary care office in Nebraska. He did his undergraduate and sort of doctorate pharmacy studies, both at the University of Nebraska. And I follow him online. We'll put his link in the profile. He is just a genius when it comes to lipids. He's actively looking at the lipid space, and his sense of humor is, I think, subtle enough that there's about 0.1% of the world can understand it. You have to be a lipid nerd and like a clinician, I think, to get it. But he's absolutely hysterical. And his choice of hats is really, really spot on. So, he's really spot on. So I'm happy to have him here. And Brian, I'm happy. I want to talk about all these things. I can't wait to get into it. I can't wait to get into it.
Well, I appreciate you guys having me on the show. It's really nice. So yeah, like you said, Dr. Tro and Dr. Brian.
Just Tro, if we
just Tro. Okay,
yeah.
Got it. Yeah. So my name is Austin, board certified clinical pharmacist. Like you said, I work at a patient-centered medical home where we house about 40 primary care physicians. I work with 3 internists, 2 rheumatologists, 2 family practice physicians. So my workload is pretty hefty, and I get a lot of clinical consults. But basically, my job kind of centers around chronic disease state management. But nowadays I kind of refer to it a little bit more as reversal rather than management to a degree. And in that space, we deploy a lot of lifestyle interventions, different modifications in that regard, some of which raise this little metric that you may have heard of. It's called LDL cholesterol. And in that context, I think what's really important is to understand exactly how that specific metric fits in the entire picture of the patient. And I think sometimes we get lost in the weeds with a lot of risk assessments and what we have a specific intervention for or drug for, and that tends to get a lot of focus. And so really my focus has been to take a step back and look at the patient holistically and ensure that we're targeting the exact intervention that's going to ultimately reduce the risk of this individual's disease the most.
Yeah, I think, one of the things that's challenging is doctors are so used to just looking at A1C, just looking at LDL, just looking at blood pressure, and our sort of modus operandi has been, take a drug, right? If you look at all of the diseases that come out of metabolic syndrome or are linked with metabolic syndrome, I mean, we can, we'll be here for half an hour talking about PCOS, infertility, hormonal issues, blood pressure, obesity, diabetes, hypertension, heart disease, cancer, right? The list goes on and on. And if you apply a drug to each one of those, you are now, doing what's called the standard of care, right? You're actually giving people 20 medications, which is unfortunately considered the standard of care. What I find interesting in you is you're a clinical pharmacist and you're actually trying to get people off drugs. So I would love to hear about how that happens, how you sell that to your practice, how you sell it to the docs that you work with. Are they aligned in your vision? Was that difficult? How long have you been practicing that way? When was your come to Jesus moment, so to speak, or, when did you see the light? I'd love to go into all that.
Yeah, all great questions. So I think my path kind of came from two different directions and converged together. So it kind of started off with this notion of every single time I would chat with the patient, which, by the way, just to give you some background on exactly what my day-to-day looks like. So typically I have phone visits every half an hour, and I work kind of as a liaison between office visits with the physician. So if the patient gets diagnosed with whatever, chronic disease state that we want to look at, diabetes, for example, then I'll be following up with them depending on the intensity of the intervention. It could be daily. It could be every week. It could be every other week. It could be every month. It could be every 3 months. It could be longer than that. But really, in that context, what I found was that it's like every single time you go to the doctor's office, it's more pills, it's more injections, it's higher doses. It's this recognition of more and more pharmacotherapy for this individual. And people just get really tired of it. And then particularly for the type 2 diabetic population, when we look at the data, when we start to get to like terminal disease where we're refractory to multiple agents, we're on lots of different drugs, then we start to dive into exogenous insulin. And at that point in time, the data on exogenous insulin for individuals that have type 2 diabetes is so abysmally poor and sad that, I feel just almost like a personal hurt to put an individual on exogenous insulin if they have type 2 diabetes and have pancreatic sufficiency. And I think the literature is pretty clear that, or at least consistently associated, that exogenous insulin probably sends a person to an earlier grave, and certainly very likely increases the risk of cardiovascular disease as well as cancer and dementia. So when you get to that point in time where you kind of feel really comfortable with all the medications that you're using and leveraging for individual patients, it gets so overwhelming to the point where you think, is there something else? And so we kind of took a step back, and I remember listening to, I think you tweeted about this just the other day, but I listened to a podcast that was Rogan, and it was with Stefan Guinier and Gary Taubes. I don't know if you remember that one, but they kind of debated low carb and stuff. And I kind of stumbled upon Red Pen Reviews. And so, I went to Red Pen Reviews and read the top books on Red Pen Reviews, Walter Willett's Eat, Drink, and Be Healthy, and The Good Gut by the Sonnenbergs, and Longevity Diet by Walter Longo, and just consumed all of that. And, I brought it back to clinical practice with patients. And, the challenge is that patients have heard that type of message just 1,000 times. And the message being, let's, eat a plant predominant diet, mostly protein from plants, try to prioritize PUFA and MUFA, try to decrease saturated fat, more fiber. And so every single time I would counsel patients on this type of recommendation, their eyes just kind of gloss over to a degree. I've heard this before. And so at the same time, I had my first kid, and I was.
So what year is that? What year is that?
So this was probably 5 years ago, 5 or 6 years ago.
So 5 years ago, you're like, I want to do better. And you start looking into nutrition and you go to Red Pen Reviews because of Stefan Guyenet, and who's a, for the person who's a listener, Stefan Guyenet is a researcher. And I think the most notable research of his that I think is worthwhile is the concept of sensory specific satiety. He has some other contributions to the scientific literature, but I would say that's about it. He wrote a book that I don't think really addressed or helped anything, but he's an accomplished researcher. But the other people you mentioned, just so you know, just to give the listener context, Red Pen Reviews is what I would say is a highly biased review created by scientists who agree with themselves. And they've decided that anybody who's low carb or alternative thinking is rated poorly. And anybody who pushes plant forward diets will be rated highly. And you'd expect that those people would agree with, people like Walter Willett at Harvard who have pushed Mediterranean diets for years, right? So just to give a little bit of context. And so you tried to do what the experts said, and it didn't really work out for you. Is that right?
I mean, yeah, I would say that. And I would also say too that, the challenge is that a lot of people know this advice, but the ability to adhere to that advice, I think, is profoundly compromised in a lot of circumstances, because unfortunately people don't really love to eat that way. And so if you're compromising a lot of adherence, then it doesn't really matter what, type of dietary pattern that you put forward. If the patient's not going to deploy it, then it's not going to be helpful for them.
Well,
and I think that's where.
So I want to come back, right? So this concept of the patient's not able to adhere, I want to immediately challenge that, right? I think that they're unable to do it because the diet is terrible.
Exactly.
Right. So meaning if you look at the literature, I'm not gonna, I'm gonna challenge you around this. Being vegetarian and vegan is associated with mental health issues, osteopenia, sarcopenia, and worsening metabolic syndrome. Now they may have less cardiovascular disease, right? So what if that they it's not that they can't adhere to it, they don't actually feel good, right? They don't actually feel good.
And there's more depression and anxiety. And I noticed that for years. And I was like, I don't want to be political, but I'm telling you, this is what I'm seeing in my practice. And you start thinking, why is that?
Yeah, no, I think that's interesting points. And, when I say adherence, I think I would say that would kind of amalgamate all of those things that you guys entailed, whether it be feeling crummy, whether it be not liking to eat that way, whether it be, worsening of mental health issues or whatnot. And there's no doubts. I mean, you see anecdotes from a lot of different, people that will swear that, XYZ diet cured whatever ailment. I think that there are some very unique characteristics of a ketogenic diet, for example, that have a lot of much more interesting biological plausibility behind some of the purported health benefits, including mental health, by the way. But yeah, no, I agree with you, Tro, in that degree where, I mean, I think it's just really hard to adhere to a dietary pattern. And my goal has always been to try to incorporate the broadest array of foods in order to maximize adherence. Because I think sometimes we often get into this trove where we want to maximize quote unquote healthfulness, and that comes at compromising adherence. And so, I mean, if you look at the dietary guidelines or whatever, and again, I agree with you, osteoporosis and osteopenia and sarcopenia and other types of conditions could be associated with vegan or some permutations of vegan or vegetarian diets. But the bottom line is, when you look at these dietary patterns, people just, it's hard for them to adhere to them. And so my goal is driving towards, more of this minimally processed whole foods, and then kind of grading carbohydrates on a sliding scale, depending on the condition that we're looking at to treat, whether that be diabetes, whether that be ulcerative colitis or mental health conditions or other things like that, and just kind of seeing how they respond. So my crusade per se isn't, I think, towards like this vast promotion of specifically a ketogenic diet, although I do think that it's a remarkably valuable tool. My crusade is against folks that are trying to, I don't know, I guess, censor or reduce the consumption of certain foods that may ultimately aid in accomplishing that endeavor by maximizing adherence, such as things like red meat, eggs, other things like animal products in particular that people enjoy, that they could probably adhere to a little bit better, but that they don't ultimately consume. And instead, it ends up being a lot of added sugars, refined starches, and other types of things that get incorporated within the diet.
Yeah, and I think it's having the right tool for the right problem, right? And that's part of it too. Is I see some people on extremes. There's a lady I talk about a lot, a doctor who weighs 96 pounds. Her sugars were through the roof, like 300 every afternoon. Her LDL cholesterol, everything, triglyceride, everything's screwed up. And I see her, and I think she's gonna be 300, 400 pounds, and she's like 96 pounds, right? And she works out 3 hours a day, eats zero carbs. So we got her to liberalize her carbs, decrease her exercise a little bit, and her cortisol dropped like 80%. And all of a sudden everything normalized. And she's like, how can that possibly? Because she was working harder and harder trying to get the sugars down, right? And she couldn't figure it out.
Yeah,
So
and
sometimes in that person, you go, okay, let's change what you're doing and see what happens.
right. And it's amazing the hammer that is nutritional intervention too, because, when you end up pulling on that lever really, really hard, just all of like the goofy things that have been going on in an individual's life, whether it be aches and pains or whether it be, mental health challenges or whatnot, they all tend to improve quite a bit. And it's pretty remarkable when we ultimately pull on that lever. But kind of, if you guys don't mind, I'll kind of jump back to my story with respect to kind of how I ultimately diverged there.
Yeah, we'll later. Yeah, sir. What the heck?
Yeah. It was kind of like the plant forward predominant type of dietary approach that I was deploying with a lot of patients. And then at the same time, I had my first kid, and so this was about 5 years ago or so, 35 pounds overweight, didn't really care about what I ate, didn't really care about exercising that much. And, after having my first kid, I kind of took a step back and I'm like, hey, I want to be around for this kid. I want to be here. I want to be able to play with him and be able to play with my grandkids, hopefully, if I'm blessed with those, and do all the things that I still love to do all the way into old age. And so I decided to download MyFitnessPal and join the gym and, track my calories. And as most people know, that goes well in some circumstances, but many times it does not. And for me, I did lose the weight, but it was just pretty miserable in the process. A lot of hunger, a lot of food noise. And the biggest challenge too was that I didn't want to like whip out my phone every single time I was like eating food around my kid or around my family or something along those lines. It's just super disruptive. And so luckily I had stumbled upon Peter Attia's podcast, The Drive, while I was working out one day. And this is like old Peter Attia, like keto Peter Attia, before he kind of decided that he wanted to medicate an entire population to lower certain metrics. And I think in that context, I tried it on myself with respect to a low carb dietary approach. I listened to all of his podcasts with like Robert Lustig and Richard Johnson and Jerry Schulman, and just devoured all of his materials. Saw a lot of success with myself. I lost a little bit more weight, but the cool thing is I just didn't feel hungry. And that was something that was really neat. And then at the place that I work at, a couple of physicians were kind of deploying a low carb approach with a couple of their patients. So I'm like, I'll hop on board and do this with a couple of patients. And it is pretty miraculous, some of the results that you can see. Some things that some physicians are like, what just happened to this patient? I've taken like some people off of 200 units of insulin per day in like less than 2 weeks, just deploying a low carb nutritional approach. It's just nothing shy of phenomenal in some circumstances.
Now, do you get any, this is what I wanted to ask you earlier, do you get any blowback from physicians you work with, or all of them are kind of on the same page? I think at first you may, and then after they see stuff, they go, wait a minute, this is weird. Like, how's this happening, right?
That's basically how it goes. It first started off less pushback from my physicians, more pushback from the registered dietitian and certified diabetes educator that worked with us. And that since culminated in, not necessarily them coming around, but they ended up not practicing at the place that I work at anymore. And they found work elsewhere. And, our clinical pharmacy staff, we have 7 clinical pharmacists at the place that I work at. And, we all are very privy to these types of lifestyle modifications. So we do a pretty good job of kind of covering a lot of those types of topics and ensuring patients understand the pathophysiology and how to ultimately eat. But yeah, I mean, you run into some issues where, you might see some nominal rise in LDL cholesterol, or at least I'm always prepared for that to happen. And the question comes down to, am I causing net cardiovascular harm in this patient? And I think it's pretty clear that the vast majority of the time when individuals are improving their body composition, it's very likely that they're lowering the risk of cardiovascular disease, probably irrespective of where their LDL cholesterol goes. I know that might be an overstatement, and there's probably some nuance that comes into play with that. But by and large, improving metrics associated with maladaptive metabolism and losing body fat and gaining muscle in the process, I think is probably the strongest mediating variable for keeping people on planet Earth for longer.
Yeah, I argued that point initially because Ben Bakiki, a couple of the workout guys I know are like muscle mass is the biggest indicator, and you look and like, holy cow, it's right. So if you're losing muscle mass, and that's why the GLP-1s and some of these drugs concern me, it's like, okay, if I'm losing weight at the expense of muscle mass, I don't think that's a good long-term trade-off at some point, right? Even if you're 10 pounds heavier, if 8 of those 10 pounds or 6 of those 10 pounds are muscle, that's not very good if you're losing that.
Well, and I think with GLP-1s in particular, which for the audience, I'm sure they know what this is, but they're medications that mimic natural proteins that the gut produces. Common trade names are things like Ozempic and Wegovy and Zepbound and Mounjaro and these types of agents. And I think the bottom line is I think a lot of folks get these drugs and they get really poor counseling or no counseling at all. They don't know how to use them. They end up vastly under eating everything, including protein. They get dehydrated, and it can lead to a lot of issues, particularly if you're continuing to eat a lot of ultra processed foods along with these medications. It's a good way to cause a profound amount of nausea and diarrhea. And then likewise too, if you're not getting adequate hydration, and I would argue salt, then a lot of these folks get profound constipation. And it becomes a massive issue. For some folks, these medications can be remarkably helpful for dampening food noise, with the goal really not to, I think, abrogate hunger or get rid of hunger. I think the goal with these medications typically is to try to modulate cravings for ultra processed foods so they can navigate towards a dietary pattern that they can eat until they're comfortably full and still lose weight. Provide the suite of micronutrients that are required, get adequate protein, and ultimately adhere to that a little bit better. So I think some people are like, well, I'm not seeing a lot of appetite suppression from these drugs when I follow up with them. I'm like, well, the appetite is probably not the big thing that I really want to be focusing on here. It's really, are you having a lot of cravings for cookies and crackers and chips and ice cream and pizza? Oh, no, I'm not. I'm eating, eggs and meat and cultured dairy and non-starchy veggies and nuts and seeds and berries. And I don't mind doing it. I like those foods. And yeah, I mean, again, it's kind of remarkable the results that individuals can experience. And then, the goal is potentially, depending on the circumstances in the individual patient, maybe we could try to de-escalate therapy, lower the dose every other week, every 3 weeks, once a month as needed. These are all kind of different strategies that we could potentially deploy in that specific circumstance. I also try to make it so, patients, again, cultivate those habits with respect to nutrition. But in conjunction with that, I would argue that while exercise is probably not the best weight loss tool for a lot of individuals, I think that it's a remarkably good weight maintenance tool for many individuals. And so trying to maintain a level of physical activity as they navigate towards weight maintenance, I think is something that I'm always trying to strive for.
Yeah, I mean, I'm hearing you, and I sense a bit of political correction because this is a professional sort of interview. But here's my problem with the GLP-1 drugs. Well, let's talk about the good and the bad. If you have really severe class 3 obesity, certainly can help, and if you have diabetes, it certainly can help. If the alternative is live a very sick life, I think these tools are, certainly interesting, but they come at a cost, and understanding those costs are important. I think we should, you mentioned my goal with this drug is to prevent you from craving junk food, right? So we should be very, very clear. We're treating addictive food with a peptide, right, to help you resist that addiction. Is that a reasonable statement?
I think you're spot on. And I've actually challenged Michael Mindrum on this a little bit, and I'm still kind of waiting for his response on
You can hold
X
your
or
breath
Twitter.
on that one. You can hold your breath on that one. Yeah, I
Yeah,
don't think you're going to get he's still worried about COVID.
right. But I think with respect to food addiction, I think when you really take a step back, I think it's really hard to argue that the vast majority, if not all, of challenges with respect to obesity just cashes out to some level of food addiction. And
so is it fair to patients, Brian? I'm sorry, I'm getting a little, I'm so passionate about this. I'm having trouble.
I love it, by the way.
I'm having, is it fair to patients that we don't describe what it is we're treating?
That was actually one of my questions for you. I think that is a very, very fair assessment. And I think that unfortunately it is just sadly kind of taboo to talk to individuals that way. But it's really, really hard to differentiate, I think, ultra processed foods from any sort of hedonic substance that drives overconsumption or impedes quality of life. I mean, how do you disentangle the two? I mean, if you can't stop eating a food, you know damn well that food is contributing to an earlier grave, and yet you continue to consume it with the full knowledge of that. I don't know how else to describe that as.
It would just be like methamphetamine or cocaine or anything, right? And
or
that's
any,
why.
Yep.
Yeah, that's why when we start talking about this, we say, well, what's happening with our patients back then, 7 years ago now? Like when they stopped eating the processed sugar like crazy, their dopamine receptors in their brain got better, right? So if you need more, if you need 12 cookies instead of just half a cookie that other people eat and they're happy, they enjoy the taste. They go, that was good. I don't need to eat the whole box. Some people eat one and they can't stop, right? So if we can intervene, and that would be a benefit of the GLP-1s. But one of the downsides to that same thing is if you're blocking that dopamine response, you don't get as much fun from eating cookies. You don't get as much fun from drinking alcohol. You also don't get as much fun from having sex with your partner and spending time with friends and playing with your dog. So depression, anxiety, stress can get worse for some people, even though they're losing weight. They're like miserable. Like people look at them and go, they're kind of miserable now. They're not fun to be with. And it's kind of a weird thing, right? You think that they're losing weight and they should be the life of the party now.
Yeah, I completely agree with that too. I have a small subset of individuals that have basically said that they've lost interest in a whole host of things that they used to find interesting. And I think it's a legitimate concern. I will tell you that on aggregate, for most of the experience that I've had, that is something that is generally a smaller subset, but still, like, it's there. And again, if people aren't monitoring and following up closely with these individuals and making sure that they're getting the proper treatment, proper counseling, ensuring that they're making the right lifestyle modifications or modifications that I think are right, then yeah, I mean, you can run into problems with worsening of depression, worsening of anxiety, social isolation, those types of things.
I want to ask you, because you're a pharmacist, and I want to segue slightly. How do you feel about the process of compounding? And maybe we could just make it external to the GLPs. And I want to understand, as a clinical pharmacist, how you feel about, sort of the new craze of microdosing. Is it just homeopathy, or am I wrong here? Like, how should the average person out there feel about compounding pharmacies? And then how should they feel about GLP-1 use? I mean, you're the expert on this. I don't think we've had anybody more qualified to talk about this than you.
Oh, geez.
So, no, I mean, I'd like if it's nuanced, let's go through the nuance.
Yeah, I mean, to be honest, we don't use a ton of compounded medications, and usually the challenge is that, there's, as tremendous barriers to entry with respect to these medications from a cost perspective. So, I mean, they're wildly expensive. Now, Lilly just did come out with a extra discount for a 10 milligram vial of Zepbound. So it is a little bit cheaper if you partition out those doses in an off-label fashion that may or may not have risks associated with it. But as far as the compounded versions goes, we typically will, like, if the physician is comfortable with sending a compounded version of these GLP-1 agonists or incretin mimetics to a compounding pharmacy, we have a conversation with that that compounding pharmacy. We know what's going on there. We know the people that work there. And we know that they have good quality control, quality assessment. But again, there's just a lot of unknowns.
So do we need to fear compounding pharmacies, or are they, I mean, you've probably compounded more than I ever have.
Yeah.
So should I fear, because they're, the agents of the pharmaceutical industry tell me to fear compounding pharmacies, that I should be very concerned about the 1 in a million who get a fungal infection from, just help me decide, because I've never been in a compounding pharmacy.
Yeah.
So give me some insight. Just tell me how I should think about this.
It's a sight to see. And, I'm not going to overstate my experience in compounding pharmacy because, I did probably 2 months of a rotation in there, 4th year in pharmacy school. I've shadowed a couple of compounding pharmacies and stuff like that. But, they have a lot of meticulous detail that they put into compounding medications. There's an insane amount of logbooks. There's a considerable amount of regulations that govern it too. It's not like the wild, wild west. I mean, it's nowhere near as problematic as, like, let's say, the supplement industry that basically, can put whatever they want into a particular bottle. And as long as it doesn't kill you, they can market it to individuals. I think that with compounding pharmacies, the regulations are decent. I also, the challenge is that all regulatory bodies probably have some level of, distrust that some people garner from them, even the FDA, right? And so I think
I don't trust them with generics. Right. I don't trust the FDA with generics.
And I swear, there are a whole host of people that I run into that are like, this generic doesn't work, this generic does work, blah, blah, blah. And you could see it on a lipid panel sometimes too. If you're meticulous enough about tracking individual patients and understand that, they were on, this particular generic this time and this particular generic this time, and their ApoB is, vastly different, then, you're probably going to, I don't know, that's a little bit of pause for concern. So I guess my philosophy with it is that, if we've exhausted all options and an individual has a clear indication for a GLP-1 agonist, despite all of our best efforts to really cultivate lifestyle changes and other things like that, then, I tell them, there are some unknowns with it. And sadly, I don't usually tell them this, but, there are a lot of people that inject a lot of goofy stuff into their body for a long period of time, particularly in like the bodybuilding community and all sorts of places like that. I wouldn't use them as poster childs for like, the best thing to do with your health per se. But I think the human body is remarkably resilient. And I think that, again, I'm not as concerned about the 1 in gazillion, fungal infection like you had mentioned. I think that it's a travesty that these patients can't get these medications at an affordable cost. I think the treatment for obesity from the insurance company is more or less prejudice against this particular disease state. And I think that, I think if the patient has a decent appetite for risk, then, we're okay with proceeding with it. How does that answer sound?
Yeah, it sounds nuanced. I think the agents of pharma that I've sort of follow and recently posted about very often call it into question, and then somehow, like all the generic drug issues you just mentioned get a pass, right? So I appreciate you taking the time to sort of answer that, because there is a lot of fears, and some are legitimate, right? Some compounding pharmacies have been shut down.
And who do we have, Tro, that was talking about the generics, and it was mind blowing? Like
Catherine Eben and her book Bottle of Lies.
Yeah, Bottle of Lies is mind blowing. You listen to it and you're like, oh my gosh, like zero quality control, like nothing. Yeah, it's incredible. And then they bought off the regulators. It's incredible. Like it's amazing. You can't believe it. But then, people can't afford the full price meds, from the manufacturer. So it's a tough problem for sure.
Well, it's exactly the reason why, I think, again, trying to deploy very effective lifestyle management should be obviously like the cornerstone. And to a degree it is. But the challenge is that, a lot of folks that are in primary care, if they're deploying the, only plant-based dietary pattern and telling people to avoid, saturated fat and other types of things like that, then, again, maybe it's just the advice that's kind of crappy that's leading to this issue. And maybe lifestyle modification could be the forefront. And you look at Unwin, other low carb doctors that have just got reinvigorated by leveraging lifestyle modification. The dude was about to retire, and then he's like back in practice. I don't know if he's like, I don't know exactly how old he is, but bottom line is, you know, he's kicking butt every single day and changing people's lives. And I think that that's a really neat testament to like the power of some of these nutritional interventions. And once physicians realize that, or they get a taste of that, it can be, I mean, it can really like reinvigorate their career, I think. It certainly has reinvigorated mine.
Yeah, we're definitely in a unique time in history right now.
I feel like you just read my diary, you know?
Yeah.
Yeah.
Well, you know, I think when you look at it, you know, I mean, I remember I hated dealing with diabetes before because it was like I knew it was coming. You get higher and higher dose of insulin, you get higher meds, then you get the ulcer in your kidneys, you start going blind, you can't feel your feet. And it's just like, oh my gosh, it's like it's a dead end. And then now we're seeing people come off all their meds and feeling great. You go, oh my gosh, like this is because we know what would have happened if we don't intervene, right? So what you're doing is saying, let's not, you know, the crazy thing is where we were in medicine, I think it's changing hopefully, is like all they looked at was the A1C. Where's the A1C? Where's your LDL? And let's just hammer that with our one drug and get that down and think you're healthy now. You're eating cookies and donuts every day and your LDL looks good. Great. Just take 80 milligrams of Lipitor now. You know what I mean? And then your sugars are crazy. It's like it's like a dam where everything's breaking at the same time. And when you can start taking those one thing out of the equation, you know, and I think, you know, it was an eye opener for me. I had Ben Bickman and we're doing a discussion somewhere. I said, Ben, if you had to choose, what would you rather have, high LDL cholesterol or high insulin? And he started laughing. He was like, well, that's like a tee up. Of course, high LDL cholesterol I'd rather have. And you start looking at that from a longevity standpoint.
Absolutely. And I mean, and we have data on that too. I mean, like, you know, if you look at tertiles of insulin, which is, you know, basically breaking up people into 3 different groups, and then you put ApoB below or above the 80th percentile. I mean, if your insulin is low, then the incidence of cardiovascular disease is remarkably low, irrespective of where your ApoB is. And it's the same kind of thing that holds true with respect to, you know, calcium scores and the power of zero. You know, Khurram Nasir has done a bunch of great studies on this, but, you know, when you look at dyslipidemia or even LDL particle count in particular, and you look at different quartiles of those individuals, you know, whether you're above the 80th percentile or below the 20th percentile, your incidence of cardiovascular disease, at least over the follow-up of these studies, is remarkably low. I mean, in MESA is the multi-ethnic study of atherosclerosis. If you look at LDL-C as a metric, as far as predicting events in individuals with a calcium score of 0, it's non-existent. 16.6 years of follow-up. And really, LDL-C doesn't track with future events in that population whatsoever. But the interesting thing is what does track with events are all the things that people are looking to reverse with lifestyle modifications, which are things like hypertension, diabetes. And oddly enough, in Western Denmark Registry, it was low HDL-C, which of course is a proxy for insulin resistance, right? And so, you know, I think if you ask yourself a couple of questions with respect to calcium scoring in particular, you know, what predicts events in a calcium score of 0? What predicts events in a calcium score that's above 0? What is the number one predictive metric that someone can measure on an individual that ultimately will tell them what the risk is for a future event? Calcium scoring. And so the answers to those questions, I think, are really what I try to focus on the most. And I think here's how I would boil down my position. You might have this in your diary too, Tro, but this is kind of how I think about it is I think emphasis on LDL cholesterol or LDLP or ApoB, if that comes at maximizing the ability to adhere to a dietary pattern that would otherwise improve metrics that are more strongly associated with heart disease, maladaptive metabolism, body composition, et cetera, then I think you're causing net harm to a patient. In other words, if you're myopically focused on lowering that LDL cholesterol by substituting saturated fat for PUFA, for example, then again, I think you're absolutely causing net harm in regards to the fact that this individual could have been eating 90% of, a lot percentage of their calories from saturated fat, improving their body composition, which is likely much more, to a much greater degree, improving their overall global cardiovascular risk profile. Does that make sense?
Yeah, yeah. I think like 100%. Maybe I know like lipidology and cardiovascular risk is like a pet peeve of yours, right? It's not a pet peeve, but maybe a topic of interest for you. I can tell you've probably read more than me and Brian combined. I don't know what Brian's read, but I certainly know you've read more than mine. I follow you on social media. I read all the studies you post. And when we talk about lipidology and cardiovascular risk assessment, it's often another very nuanced topic. So I want to hear how you counsel your patients, right? How you talk to them about cardiovascular risk, how you interpret. You are by training a doctor in pharmacy. So when should I think about a statin? When should I, if at all, when should I think about ezetimibe? When should I think about an injection drug to lower my cholesterol? When should I think about? So help me understand, because I think you have a particular expertise here. When these drugs are more likely to be, it's sort of like antibiotics. Like, if I have a sore throat, you're not going to give me an antibiotics, but if I have a sore throat, pus coming out of my, tonsil and a lymph node and a fever, right now, just for the listener, that's more likely to be strep throat by center criteria, right? You're more inclined to consider an antibiotic. So help me understand, do I need to care about lipids? Who needs to care about lipids? And what drugs and what supplements or what other strategies, how should I approach cardiovascular disease risk? Because, cardiologists online say one thing and your subtle humor suggests you may disagree. So how do I approach this?
Well, thanks for describing it as subtle. But yeah, I have the unique job because I get to spend a lot of time reviewing lipid panels and reviewing coronary calcium scoring. And I get a lot of time to actually spend with the patients. And in a model that is driven by fee for service, like it is in a lot of primary care, a lot of physicians, unfortunately and sadly, don't get as much time as I get to spend with the patient to kind of help them understand the risks and benefits associated with this, all the things that are going on in their body that culminate or amalgamate into these metrics that we're like reading on a lipid panel, for example. I do kind of call it, you had mentioned antimicrobial stewardship. It's kind of like lipid lowering therapy stewardship to a degree, I guess. But yeah, I mean, the way that I look at it is really trying to integrate all the metrics that I see on a lipid panel and giving me insight on what the heck is going on with respect to how well their metabolism is functioning. And I think a lot of people think of these types of metrics and other quote unquote risk factors in an isolated fashion, when in reality, all of them are very intimately tied together. And that's one of the biggest problems, I think, with ApoB or LDL cholesterol in general. ApoB being the structural protein that wraps up lipids that helps traffic basically sources of energy into the body to all the tissues. And LDL cholesterol being part of the internal and external component of that ApoB that is there basically along for the ride to a degree. And I think, ApoB could probably be elevated for good and bad reasons. And I think it could probably be elevated, it could probably be low for good and bad reasons too. And I think looking at the patient as a whole and teasing out that entire clinical picture is remarkably important. And I think it's also worth acknowledging too that we just don't understand every single thing about cardiovascular disease, period. And there's a lot of risk factors that, there are a lot of folks that have hypertension, for example, or sky high LDL cholesterol or diabetes that don't ultimately end up developing heart disease. And likewise, there's a people of a touch of those diseases, and they have profound peripheral neuropathy, and they're getting lower limb amputations and stuff like that too. So that's why
I gotta pause you. I gotta pause you here because Brian his eyes are like glowing here, and I know he's probably super. What do you mean? We don't know everything about cardiac disease. I have been told by cardiologists, if you lower LDL below 60 or ApoB, I guess below 80, you will not develop cardiovascular disease. So the listener may not know, I'm slightly being sarcastic, and I know you are sensing it. So what do we know about cardiovascular disease? And you said there's a lot we don't know. What do you suspect is at play, given like more than most. So
I don't know about
what
that,
do you
but
what do we know, and what do you suspect?
Yeah, I'm not going to pretend to be like an absolute expert in this field, but what I would say is that, when you look at Miami Heart, for example, which is a population cohort of middle-aged individuals, supposed to be kind of quote unquote relatively healthy. It was like 1 in 12 of those individuals that had an LDL-C less than 70 had a calcium score greater than 100. I mean, how much lower do we need to go to prevent those individuals from developing such a profound burden of atherosclerosis? And there seems to be kind of this dichotomous cutoff between, low and much higher risk when we start to get much beyond 100. And certainly 300 would be kind of like equivalent to an individual that's had a heart attack or a stroke before, per some of Dr. Budoff, some of Dr. Budoff's work. So yeah, I mean, I think that's one of my other flip sides of my crusade. One is, hey, let's eat all whole foods as much as we feasibly can, including things that, are kind of like taboo for health or weight loss in general. And then the other flip side of the coin is just because you have low LDL cholesterol doesn't necessarily mean that you're just like totally safe from cardiovascular disease. I mean, it's insane. I think we have enough data out there that points towards us not knowing. And I think doing the imaging to really understand what your current burden of disease is remarkably beneficial. You could look like an absolute train wreck on paper, but if your calcium score is 0, particularly depending on how old you are, but generally speaking, if your calcium score is 0, at least your short-term risk is relatively low for a major adverse cardiac event. And you could look like the best thing since sliced bread, maybe not sliced bread, I don't know, roast beef or something. But if you got a calcium score that's high on paper, it's not good. And we should be, remarkably aggressive about all different lifestyle and pharmacotherapeutic options, if that's something that a patient is willing to partake in order to abrogate that risk. And so, yeah, I mean, I think there's this myth that, as long as your LDL cholesterol is super low, and, unfortunately it's sad, but the, goal keeps going lower and lower and lower. And again, I'm okay with evolving data. I'm okay with people reassessing and being like, hey, in these particular subgroup analyses, we see that, if we get it lower and lower and lower, we tend to see a lower risk of major adverse cardiac events. That's fine. But it comes to a point in time where there's so much residual risk at such a low level of LDL-C that it's like, maybe we really need to be focusing on some other aspects and really hammering those a lot harder and doing things like you guys are doing, which is really trying to maximize adherence to a dietary approach by providing a lot of intensive and holistic care through excellent patient communication, through apps and otherwise. And sadly, that's partly, one of the issues with primary care is that model is just not designed for something like that.
Well, I think we've lost focus of saying, okay, like our job really, that patient in front of us, say, what's the most likely thing to kill you or cause you problems, right? Let's look at that first. So when we look at insulin, high A1C, that's the elephant in the room. Like you see that in an LDL of 120, and that patient scares me, right? If someone has an insulin of 2 and their A1C is 4.6, I feel a lot better if their LDL is 180. It's like, okay, I'm not too worried about it, right? So you start looking at the whole big picture and what's their CRP and the inflammatory markers for the heart and all those kind of things. And I'm curious too, just from your standpoint, because you have different experience than we do, different patient population with rheumatologic diseases. A lot of these patients have markedly elevated CRP. Do you see markedly increased cardiac risk for those patients?
Oh yeah, absolutely. I mean, rheumatoid arthritis carries an adjusted hazard ratio for cardiovascular disease that's very, very close to, or at least on par with, diabetes. And so, these folks, have a lot of problems. What I, particularly with the cardiovascular system, what I will say,
they have low LDLs.
And they have low LDLs.
Low LDLs.
This is true. And I'll send you guys this paper. There's a really, really interesting paper that LipoFan had sent me on RA patients, or at least he had posted on it. But really, they're kind of, it's called like the LDL paradox in RA, where, individuals that have really low LDL-C in that context see this rampant atherosclerosis. And really, I don't think, I don't know, I could speculate and do a little bit of, I don't know, mechanistic hoopla. But, I think, like you had kind of touched on with that podcast with Allo and other podcasts, I think LDL certainly plays a role in the immune system. I think it probably mops up a lot of junk that's in the bloodstream, including reactive oxygen species, excess glucose, a lipopolysaccharide, which of course is, a piece of protein that's found on bacteria, that could be from maybe a source of gut permeability or leaky gut, like people like to say. And, ultimately, when that LDL-C gets quarantined into the intima, probably through a level of active quarantining. In other words, there's like this way of phrasing things like the ApoB or the LDL-C crashes your artery wall. And it's like this, massive passive diffusion type of thing where, the more particles you have, the more it's just diffusing across. I mean, just from a pure physics standpoint, that just like makes literally zero sense. I mean, I don't know if anybody's ever heard of this thing called a glycocalyx, but this is like massive weave of basically different glycoproteins that you can't just get an LDL particle that's just like weaving in and out through there and then just, shoving its way through a cell. This is a process that is probably designed, in my opinion, and again, I could be overstepping, but this is a process that's probably designed by the human body to take in these LDL particles, traverse them to a space to get rid of by the immune system, by macrophages. And it's the process of the inability to resolve that inflammatory response that ultimately results in probably an atheroma and ultimately the rupture of that atheroma that ultimately results in a clinical event. And for folks with RA, I think they probably, I mean, they clearly have, in my opinion, a lot of gut issues that coincide with this low-grade chronic systemic inflammation. And they probably have a lot of their LDL particles that are getting pushed into the intima. And that's why we see this low LDL-C and this rampant atherosclerosis, particularly in the toxic food environment that these individuals are placed in. So that's kind of my thought.
And plus with the, rheumatologic disease, I mean, a huge correlation with stress, anxiety, things that happen, traumatic events before they get the onset of these autoimmune diseases. And we forget about the gut microbiome. And I think that's a huge part of it. And when you change your diet, you're fixing some elements of that.
Yeah, and I don't know. I don't know how you guys both think of the gut microbiome. I think right now I feel like it's kind of a black box, and maybe that's just an excuse because I'm not as super privy on literature with respect to that, or I keep up with it. But it just seems like it's really hard to correlate anything in particular strongly with, I don't know, any sort of specific outcomes. What I do think though is remarkably interesting though is that when you look at the molecule that is beta hydroxybutyrate, it is a remarkably efficient fuel source for gut epithelial cells. And so what you're probably doing in that circumstance when you're getting into that state of ketosis or nutritional ketosis is that you're probably giving your gut lining a really, really efficient fuel source that is perhaps to a degree healing it, which is why, again, having this experience with RA patients, I see profound improvements in a lot of their disease activity and symptoms when they lose weight, but particularly when they go on a ketogenic diet. It's wild. And we do have a subset of individuals that are doing like a zero carb, carnivore, whatever you want to call it, type of dietary pattern. And yeah, I mean, it is kind of like the Michaela Peterson effect in some individuals. It is basically miraculous. People are kind of shaking their heads. And I think there's a lot of, like I mentioned, I think there's a lot of biological plausibility behind it. Ketones dampen inflammation. Ketones help the gut epithelial lining.
It's really interesting, Austin, because a lot of carnivores that I know, that patients of mine, they went carnivore because they had so many gut issues, and they did it as an elimination diet, and they got so much better. And sometimes we look at their gut, and it's still kind of a mess. Like they don't have much gut lining, and they have leaky gut, zonulins high, and all that kind of stuff. What I found that's really intriguing to me right now, and I think in 5 years, Tro's going to say you were right, Brian. But I'm seeing a fair amount of carnivores. And if I see carnivores with really high LDL cholesterols and high triglycerides, because that's abnormal. Their triglycerides are usually in the 50s and 60s in my experience. Sometimes I see it in the 200s, and I go, let's look at your gut, leaky gut. I just had 3 this week, leaky gut. Leaky gut, high triglycerides on a carnivore diet. And I'm like, it doesn't make sense from a Dave Feldman perspective, why would your triglycerides be going up when you're not throwing a lot of carbohydrates into the system, right? It doesn't make sense. So this thing
Yeah.
leaking across and inflammation, and like you're talking about lipopolysaccharides and what that inflammatory effect on everything.
Yeah, I think that's super perplexing. And I'm not entirely sure as to why that happens in some circumstances. I know Dave Feldman has elucidated some, things on his blog, for example, people that have like a coffee sensitivity. Apparently it's not caffeine. Apparently it's not specifically any sort of methyl xanthines or something like that that's found in the coffee. But for whatever reason, some folks have this, massive triglyceride spike when they have coffee in a fasted state. I also don't know, like, I would be interested to see how long that individual was fasting too, because sometimes the triglycerides can just drop off a cliff after, 2 hours. They can stay elevated for a significant period of time, and then boom, they just drop like a rock at maybe hour 12 through 14 or something along those lines. But yeah, that's really perplexing. And those are the types of circumstances that make me scratch my head, make me worry a little bit. I'm like, what exactly is going on in this individual's body? But the bottom line too is that I think oftentimes we forget about the subjective experience of the individual too. Yeah, okay, let's just say I get a patient that comes back that has, hypertriglyceridemia in conjunction with elevated ApoB. But let's just say, like, for the first time in their life, they were able to get out of bed without pain and walk to the bathroom and brush their teeth without feeling horrible. I mean, you can't downplay something like that. And so, I've actually had an RA patient tell me that if this disease takes my heart, then so be it. I'm willing to deal with that in order to actually have a functional capacity. And luckily, we have some pretty decent agents that probably in lean mass hyperresponders, that phenotype that ends up resulting in markedly high ApoB on a low carb diet. There are some potential therapeutics. Maybe we can reintroduce carbohydrates to a degree, or maybe they can reintroduce carbohydrates into exogenous ketones. Maybe ezetimibe too. I know Tro's like super privy. You guys are super privy to that type of data with respect to that specific agent in that population. So yeah, I mean, I think the bottom line is a lot of folks will feel so much better on a dietary pattern, and I think that gets dismissed as like, oh, you feel better when you're on cocaine, feel better when you're on meth, and stuff. And I think that's just absolutely a bunch of crap, because you don't know what it's like to feel super. It's clear to me that these folks don't know what it's like to feel super depressed, suicidal, having profound anxiety that gets alleviated, or other mental illnesses like bipolar disorder or whatnot. Until you've walked in those shoes, it's just really hard for an individual to kind of comprehend how bad that is. And that's, I would say that that's one of the other reasons why I try to stick to a probably as low as carb as I can feasibly get for me as an individual. I would say that a lot of folks come into low carb for the metabolic body compositional benefits. And I feel like a lot of people stay because of the mental health benefits that they see from it. That cloud that's over you, or some of that anxiety, sometimes it doesn't always go away, but it certainly dampens quite a bit in a lot of individuals to make it, a little bit more manageable. And then once you start to feel that way, then you can be more meticulous about different tweaks in your diet. And obviously, if you take it to the extreme, you have some folks that are, doing some goofy stuff with respect to wanting to avoid every single thing that you could possibly imagine that could be causing problems, and they're walking around with their shirt off and screaming at people and stuff like that. But I think you might know who I'm referring to. By the way, love his content too. I love all content from all people. But I think the bottom line is it's important to weigh in the subjective experience of the individual.
Yeah, 100%.
Yeah, and if you can make their quality of life better, if you're in chronic pain with rheumatoid arthritis and you get that inflammation better and you get that pain better, then you want to go hiking and you want to go do stuff and you enjoy life, and you're not sitting there saying, let me eat cookies to feel better, and that's going to make your inflammation worse. It's hard to break that cycle when you're not feeling great.
Right.
And you're depressed and bummed and, frustrated with people and everything.
I
think it's remarkably important. I completely agree. Yeah.
Absolutely, guys. I cannot stress enough how much I think in agreement we all are. I think every patient deserves one time, a little bit of nuance, and look, just not reflexively, nothing in medicine should be reflexive. It should all be individualized. And it sounds like that's the type of care you're providing in Nebraska. In Nebraska, we got to get you to come back another time, and we got to go deeper into the PISA
Wait,
study. We got to go, yeah.
Austin, I see all these guitars in the background. What's your favorite song to play?
Oh God, so many. I'm a big Led Zeppelin guy. I don't think I could. I don't think I could pin it down to one guitar. You see that? I don't know if you
Oh
can see
my
the
gosh, you got
Cherry Sunburst back there. A little Jimmy Page action, but he's the lead guitar player for Led Zeppelin, one of my favorite bands. But yeah, I like all music though. It doesn't matter if it's like heavy metal or if it's Taylor Swift or if it's Billie Eilish or if it's Led Zeppelin.
You just said, whoa. We're done here.
Wait a minute.
Oh
We're
no!
done here.
Oh no!
We're done here.
We'll do the Led Zeppelin, like, some chill acoustic stuff. We should have you back because I was thinking from the beginning, I go, you have a really relaxing voice.
Oh, well, thank you.
Like you calm patients down. They come in stressed out and they go, oh, send them to Austin. Calm this person
Well, I got to
down.
give a lot of news about, high calcium scores. So I've tried to, tamper a lot of.
Wow, they just throw that on you and let you deal with it, huh?
Oh, they do. Yeah. But it's okay, because I get to spend a lot of time with them. And I think I think out of all the physicians that work with me, I think they feel, like I'm a trusted resource for a lot of patients with respect to going over that kind of data, just because I've, mulled over it a gazillion times before.
And what do you advise that? What do you advise people like they have a high coronary calcium? Are there any? Yeah. I hear this thing about concentrated K and different things that are supposed to help reduce coronary calcium. Troy, have you had any experience or Austin of seeing something you go, hey, this might be a legit at least if we can keep it at that level. So I will tell people like you haven't had a heart attack yet and you're at that level. If we can keep it there or like reverse it a little bit.
Yeah, I don't really know. So, I mean, I kind of think about calcified plaque as far as a CT scan. And again, you guys can correct me where I'm wrong here, but I kind of think about it as kind of like a scar. We wouldn't really want to surgically remove scars from individuals as long as they're not impeding any sort of quality of life from a functional mobility standpoint or otherwise. Really what we worry about is all of the cuts that might be open and infected and causing sepsis and ultimately leading to a patient dying. So, I don't really think of like trying to lower a calcium score as potentially like a great thing to do. It could be, I would, and again, I would be totally open to changing my mind on that if there was any data that ultimately would suggest that. But I think of calcified plaque as more of like a risk marker rather than something that is necessarily a modifiable thing. I don't know. Do you think of it?
Yeah, I agree with you. And I think like trying to reverse that because it's not the calcium that's the problem, it's the plaque, right? So when you start looking at that, it's like if I can reduce your calcium, push the calcium somewhere else, well, then does that destabilize your plaque? You may be better just keeping it where it's at. Troy, you may have a different opinion, but it's say, okay, if I know it's there, I want to decrease inflammation as much as possible. And not have an inflammatory effect with platelets and everything sticking to that and causing an issue. So it is, and the hard thing is it's so stressful. So I have people like just yesterday, I was saying he's been on a statin drug for 40 years or 30 years. He goes, I want a coronary calcium. I'm like, I don't think you do. It's going to cause you so much stress because it's going to be high. If it's zero, then I feel better. But if it's high, I'm like, I don't know.
I think it's a legitimate concern.
Yeah.
I think it's a legitimate concern. I think, it does cause some stress for individuals. I think you have to just basically, tell that to the patient and help understand where they're coming from too. There are some folks that are like, ignorance is bliss. I'd rather not know.
Mm-hmm.
Let me live my life. This is how it's going to be. And if I die, I die. And if I live, I live. Great. And then there are some folks that want to know every single detail about every single aspect of their medical happenstance. And then there's everything in between, right? So yeah, I mean, I do think that there's been situations where some folks have called me back and been like, you gave me a death sentence. You told me that I was dying.
It was there already. We just saw it. Yeah, I know.
And I always want to level with them that when we do see calcified plaque, for example, this is a thing. It's not the thing. It's not, and there are things that we can do about it. We have a lot of amazing lifestyle interventions. And, to a degree, we have some decent tools in the toolbox with respect to medications that can potentially, in subset of individuals, help potentially. And so yeah, that's kind of how I go about, counseling folks on that. But I'm not really in the business of trying to reduce calcified plaque in anybody. I would prefer not to see it progress at all. I think it's interesting that there is some data on beta hydroxybutyrate actually causing accelerated calcification in some animal models, which is really kind of interesting. I don't know how that translates to humans. I don't know if that would mean that if folks go on a carnivore or ketogenic diet, that they would see all their soft plaque calcify faster, similar to things like statins. It'd be great to get a intravascular ultrasound study on that and look at all of that stuff in great detail. I really hope Dave et al. Do that in the future, because
Yeah,
all
that's an
that stuff would be
interesting
really helpful.
that's an interesting one too, because it's interesting, and I don't know how they're controlling for it, because I know like long distance athletes, people they'll have higher coronary calcium scores and higher sugars and cortisol a lot of times because they put their body under the stress. So it's kind of an interesting thing, because what he found initially, it looks like they had lower coronary calcium than the general population, even with super high LDL cholesterols. But I
Right.
think it depends if you're just a naturally thin person or whether you're like a huge athlete. I think there's a lot of nuance to this.
Absolutely. And again, just like any biometric, even coronary calcium, I feel like we're still learning a lot about it. And there are probably other ways to quantify density and, the not just the total absolute value, but also, where it's at different branch points in the coronary tree and other things like that that could probably refine that metric. And we'll learn a lot more and try to refine better and better. But again, there are a lot of folks that, have a lot of calcified plaque. The Maasai is a great example of a hunter-gatherer tribe that are riddled with subclinical atherosclerosis, but the rate of events for that population is remarkably low. And, you can invoke all the counter arguments like, there's a survivalship bias or whatever you want to call it, et cetera, et cetera. But I think I have a little bit of trouble with reconciling some of that type of data with the fact that, just having a higher calcium score is always a higher risk factor for heart disease. And again, the thing is, though, is like these are all academic discussions. These are fun things to talk about. I'm not playing Russian roulette with anybody that I ultimately, encounter. So, based on the data that we have, if your calcium score is high, I'm going to be aggressive with every single modifiable risk factor that I can be aggressive with, period. And I don't know, you guys might feel a little bit differently about that with respect to, LDL-C or ApoB, but yeah, I'm aggressive with hypertension. I'm aggressive with, I actually follow C-peptides in patients because I think that's a pretty decent proximal metric for metabolic dysfunction. And really what I always tell them is that the number one mediating variable that you can do right now to improve not only your risk of cardiovascular disease, but probably death is going to be improve your body composition. Let's lose body fat. Let's gain some muscle. That's what we really want to be focusing on. And then we can use our mops and brooms to kind of, pick up the slack along the way and do whatever we can to, push you in the right direction that we want to see to keep you on planet Earth for a longer period of time without dying.
Yeah,
Good stuff,
100% can't agree more. Brian, just to rattle off, my review of plaque, coronary plaque, and what I've seen, and I'll start with sort of pharmaceuticals and I'll work my way down. The drugs that have been shown, I'm not talking about side effects. I'm just talking about drugs that have shown to reduce plaques are statins, but they increase calcification, like you all mentioned. The PCSK9 inhibitors suggest that there's some suggestion that they decrease calcifications while they reduce plaques, but they have not been shown to reduce all-cause mortality or cardiovascular mortality.
Increased all-cause mortality.
Yeah, well, they have not been shown reliably to improve cardiovascular or all-cause mortality. So they do not. We can't say it is a numerically higher number, but not statistically significant for increase in. And then for cardiovascular and all-cause mortality, the bempedoic acid has been shown to reduce plaques, but not decrease all-cause mortality. They tend to work better in people who have inflammation of no unexplained cause. But the other drug is ezetimibe, which has been shown to reduce plaques, not all-cause mortality, and has been shown to reduce cardiovascular death. Vascepa, which is prescription-grade EPA, has been shown to reduce soft plaque and reduce cardiovascular deaths, but not all-cause mortality. That's it for the drugs. I don't think any other drug has been shown to reduce plaque. Colchicine has not been shown to reduce plaque. It's widely touted as a potential option in secondary disease. And then if you go to the supplement side, I guess we can lump in aspirin there as some merit but it doesn't have any effect on plaque. But vitamin K2 has been shown in human studies, it seems to prevent plaque progression or calcification, the progression of calcification. Not great data, but some data there. I think it's a low risk, but unclear reward scenario. The other supplement that I think is interesting is nattokinase, which has been shown to, early data, so not definitive, but been shown, which is the fermented enzyme of basically soy. The enzyme from fermented soy, that's been shown to be associated with reduced carotid plaques. But again, no great studies to show if it has any impacts on any any of those outcomes that we talked about. So those are the only things I know. I think there's some other like supplements out there that, for endothelial dysfunction, some people talk about vitamin C, vitamin D, vitamin E, I don't, and then also some people talk about using phosphodiesterase inhibitors if there's endothelial dysfunction. But that's all I know, and I don't feel solid about any of that either. They all come with a price, so I think what you guys have just talked about here is the need for like sort of a nuanced discussion about all of this. So that answers it. Hopefully that answers
Good
your
stuff,
question.
man. Yeah, very good.
Austin, always a pleasure. Sorry that I yapped away here at the end, but it's always a pleasure. We got to bring you back to talk about pizza. That's what we got to do. We got to bring you
That would be
back to talk
great.
about
Yeah,
pizza.
yeah, let's do it.
Yeah, I love it. I love to dive into those PCSK9 trials too, and kind of give you my perspective on all-cause mortality, because I think that would be kind of fun to go
All
back
right,
and
guys.
forth.
So
Yeah, we'll have to
you
do
all
that for
heard
sure
this.
because I think that's important. Yeah.
This is part one. Part two is coming
Yeah.
up.
Awesome.
Sounds good, guys.
Austin, thanks so much.
Yeah, thanks, guys. Have a great
Have a
day.
good one.
If you enjoy the show, please consider supporting us on Patreon by going to lowcarbmd.com.